really quite well. So it began to germinate in the minds of urologists that perhaps we were overtreating patients at that point, and it was fostered by some data that was in the lay press regarding overtreatment, the concerns regarding the side effects, risks, and complications of treatment, that perhaps we didn't have to be so aggressive. Now, things have changed over time. We've certainly we've been adopting it more and more over time. But we also recognize that there's a pathophysiology involving occult disease, that which we don't find, that which we don't see. And so that tempers what we do and how we manage active surveillance. We've come a long way to identify what we consider the baseline parameters. And really what you're looking there at are things like race, age, the PSA density, other biomarkers that have now really come online, and with a significant and large amount of research that continues to be done. There were at least 2 new papers in the Journal of Urology in January last month on active surveillance. So the goalposts kind of keep moving on this game, and that's clearly a good thing. We also recognized over time that the concept of PSA kinetics, that is how PSA changes, is that an indicator of progression of disease. And we're certainly very focused on PSA. We all are. Anybody who treats it, anyone who has the diagnosis, clearly focuses on PSA. But at least with regards to active surveillance, we sort of come to an understanding that changes in PSA don't necessarily indicate or portend progression. So it's really recognizing that that alone does not always represent worsening of disease. Along the historical timeline, we certainly have now development of multiparametric MRI. That has really changed how we manage disease. We still have some deficiencies, principally in insurance coverage, especially prior to the first biopsy. But I think efforts are being made, and with additional literature and studies that are demonstrating the utility and the value of early MRI imaging for patients. And of course, as time goes on, we have longer follow-up. We're able to follow patients much longer. We're able to see the natural history of the disease, both in general within the population, but also in individuals. And so all of this adds to our knowledge base to be able to really provide a better quality care. So what are the basics? What do we really know? And of course, what we don't know is the corollary of prostate cancer, and certainly early prostate cancer. Since the inception of active surveillance that started being used, we have a lot more information regarding the molecular genetics of both Gleason pattern 3 and 4. When you look at Gleason 3 disease, it really resembles normal cells in most cases. There are particular markers of the genesis or the development of cancer. And some of these include cellular proliferation, how quickly the cells are dividing, what we call programmed cell death or apoptosis. All cells have that since there's no immortal cell. So looking at those sort of issues can be an indication of oncogenesis. Angiogenesis is another one. That's simply the growth factors for the development of blood vessels, and clearly tissue has to have blood in order for it to grow. So these are markers that are typically lacking in Gleason 3 disease. Now, not all Gleason 3, and so as you can see here in that slide, not all of them are expressed or minimally expressed in Gleason 3 or Gleason 4. PTEN loss, though, is one of those markers that can be seen in Gleason grade 1 or Gleason 3 disease. About 10% in those grades versus 90% in Gleason 4 or higher. Now, PTEN is what we call a tumor suppressor gene, and it really is a key event in the development of invasion and metastasis. But it's only one marker. It's only one variable. And in isolation, it typically doesn't do a lot. It really requires other changes, other mutational events for it to really trigger that process. So we look at those markers. We look at Gleason 3, and there's been a lot of studies that show that the metastatic potential for a pure Gleason 3 is really close to zero. There's maybe a small number, again, having some of these other markers, and the more markers, the more variations that you have, you could certainly have a more aggressive Gleason 3 than you would first imagine just looking at the grade. That's really kind of borne out when we look at biological grade progression. How often does that cancer, how does that Gleason 3 progress to a Gleason 4? And at least in large volume Gleason group 1 or Gleason 3 disease, it's about 1 to 2%, and that's been demonstrated in multiple studies. So it's not very fast, but it is something that we have to be aware of, that those changes can occur. And it's important to look, and I'll point that out in a later slide, that there is a difference with regards to the volume of disease. That may be a better predictor of progression of disease. More volume, greater than 50% involvement can certainly portend the actual presence of grade 4. And that really is the driver in the majority of these cases. It's going to be the presence of grade 4 that may or may not be able to be identified. So if we look at that occult disease, that really becomes the weak link in active surveillance, really not identifying the presence of more aggressive disease coexisting with that low-grade Gleason 3. And it's estimated that misclassification occurs in about 25% of cases, about a quarter of them. So it's a sobering fact, and we need to keep that in mind with regards to how we do our protocols and our follow-ups. We've come a long way with being able to perhaps be able to predict or identify it earlier. So multiparametric MRI and the utilization of molecular biomarkers are clearly going to enhance our diagnostic accuracy, and they do complement one another. And with the more recent identification of the potential for germline mutations, here we're talking about the BRCA1 and the BRCA2, ATM, CHEK2, other genes that are involved in DNA repair. These are individuals that we can identify now early on. We have better insurance coverage for these kind of tests. And so these are individuals who are going to be at higher risk for progression, and therefore perhaps if active surveillance is chosen or elected, that we're going to follow them much more closely and much more diligently. We have some information long-term regarding the relative safety of active surveillance as a management technique. We can look at the PROTECT trial that came out of UK, beginning back in 1999 and going to 2009. These are individuals who were randomized to active surveillance, radical prostatectomy, radiation therapy, and had a median follow-up of 10 years. And what they found in this group, that with regards to cancer-related or all-cause mortality, there was really no difference among them. The active surveillance group did have a higher risk of progression, probably not really unexpected, but we're able to see that at least the lethality is pretty much equal across the board on those three groups, and therefore active surveillance is a reasonable option with diligent follow-up. The PIVOT study was a U.S. study from '94 to 2002, and please note that these started pretty early on. Okay, so the method, the techniques, the tools that we use to follow are clearly different now, as well as some of the standards. Pivot was a little unusual because it had a significant percentage of African American men. The median overall survival was 13 years on prostatectomy versus 12.4 in observation. So those are pretty close. The prostate cancer specific death, 4.9% in men in the RP, and is a little bit higher than those in the observation group. There really wasn't a statistically significant difference between the treatment and the observation, although again, it seemed to favor higher death rate for men assigned to observation. But this study did have some issues. It was relatively underpowered for the number to really show a strong statistical significance enrolled. And then there were also issues with a shorter life expectancy based on a number of factors. So all of that could have influenced the outcome with that. And then there was a Swedish prostate cancer group 4, again, early recruitment. This was randomized to radical prostatectomy or watchful waiting. Now, there was no immediate treatment or active monitoring on watchful waiting, which is clearly not what we do. And of course, we also have different terms now. Watchful waiting is something that we typically are looking for men who are much older, who have a lot of comorbidities, and that we're going to monitor them for palliation, and so that their disease has a less chance of causing them problems as compared to offering them definitive therapy. They were followed until 2017, so that's about 29 years, so very, very long legs on this particular study. Men with localized disease with longer life expectancy gained about 3 years who underwent surgery. So you'd look at that and say, well, gee, maybe active surveillance or watchful waiting isn't very good. But the one thing to take a look at is that those individuals who are on the watchful waiting, a substantial proportion of them actually did very, very well. So it at least supports the concept of active surveillance with appropriate selection. And that's pretty key here as we go along. So very low risk prostate cancer. It's really now recognized as standard of care that should be offered for men. These are individuals who are going to have very low volume disease. It's going to be either non-palpable disease or we call it T2A, which would be less than 1/4 of the prostate, that there would be an abnormality on exam. They would have PSA levels less than 10, and you'll have the percentage of the cores of less than 50%, at least in low risk, very low risk. They have to have no more than 3 cores, or actually be less than 3 cores with prostate cancer to be considered very low risk. And when you look statistically at the number of new prostate cancer diagnoses, most cancer still has relatively low risk characteristics in the US. It does, however, require careful monitoring through repeated assessments. That obviously includes laboratory. It's going to be your PSA, the use of some of the newer biomarkers, such as Prolaris or Genome DX. The molecular markers are there. There's some new ones now looking at exosomes in the urine. And so a number of new ones that are coming on. We recently completed 2 trials here at Genesis for both blood as well as urine markers. So again, a lot of work being done in that sphere. Imaging, of course, now with the advent of MRI, as well as unfortunately repeated biopsy. The goal, of course, with active surveillance is to delay or obviate the risks that are associated with the definitive treatments of radiation or radical surgery. Now, of course, if someone's on active surveillance, the concern is going to be, well, what's my risk of this progressing? And clearly, the worst progression would be seen if there was metastatic disease. And multiple studies have shown that the risk of metastasis is really affected by 3 main factors in the long term. Coming out of UCSF, actually just last year, this is a study that there was 450 men on active surveillance, and dating back to 1990, 2018, median follow-up is 77 months. 90% were Gleason group 1. Gleason group 1 is Gleason grade 3, 3+3. And then there was about 10% that had Gleason 3+4, grade group 2, on the initial biopsy. So overall, across both groups, 99% of individuals were alive at 7 years without metastasis. When you parsed out the Gleason group 2, 96% were alive at 7 years without metastasis, but that was a statistically significant difference between the 99% and the 96%. So again, one has to pause for thought to look at Gleason 3+4 as being good candidates for active surveillance, and I'll talk more a little bit in a later slide on that. There are other factors besides the Gleason grade, and that's PSA velocity. How quickly is the PSA changing? And then on multiparametric MRI, whether there was the presence of PIRADS 4 or 5. These are the higher lesions. I'm sure Dr. Schwartzberg will probably go over that next at your next meeting with that. But these are areas of concern that may be harboring higher grade disease and more aggressive disease. Other factors with regards to active surveillance, this information here on multiple negative biopsies actually was just presented last month in the journal, out of UCSF. So unadjusted 10-year treatment-free survival. So that's looking at men living 10 years without the need of definitive therapy. So in individuals who had consecutively negative biopsies, so their initial biopsy showed malignancy, they went on active surveillance, and then they had subsequent biopsies, 2 or more, that showed no malignancy, 84% did not require any treatment. For those individuals after their initial biopsy and going on to active surveillance, if they had 1 negative biopsy, it dropped their treatment-free survival dropped to 74%. And for those who continued to demonstrate malignancy in their follow-up biopsies, it was 66%. Concern always with African-American men. We know that African-American men are at risk for earlier prostate cancer and more aggressive prostate cancer. They often show with higher stages for various reasons. And this was 10-year cumulative data. This came out of here at UCSD. Higher incidence of disease progression. You can see about 59% for African Americans versus 48% for non-Hispanic whites. Higher incidence of definitive treatment requiring it, 54% versus 41%. But when you really look at these kind of critical parameters of severe progression, there was no increased risk of metastasis, 1.5 versus 1.4%, very, very low for both, and really no difference between the two. There was no increase in prostate cancer specific mortality, that is death due to prostate cancer, 1.1 versus 1.0%, and no increase in all-cause mortality, is death from any cause, 22.4% versus 23.5%. So this is really sort of some good foundation for us to be able to offer to African Americans to consider active surveillance for them. Clearly, with younger individuals, those who are sexually active, they may be able to safely then delay definitive treatment with active surveillance, but be able to do so with a good level of safety. But again, continuing with very close monitoring for them because of their higher risks. When we look at predictors for reclassifying on follow-up biopsies, that is, their biopsies now demonstrating higher grade disease, we see that their higher genomic score. Now that's looking at Prolaris or Genome DX, that they would then demonstrate that higher risk that in future biopsies we're going to identify higher grade disease. The kinetics again of the PSA, how quickly is the PSA going up, the PSA velocity, the PSA density of 0.15. PSA density is a number that is generated by dividing the PSA level by the volume of the prostate, either by MRI or ultrasound examination. And we have a cutoff of 0.15. And The easiest way to kind of think about this, if you could imagine in your mind that you had a prostate the size of a golf ball in front of you and a prostate the size of a basketball. And if you had the small prostate, the golf ball, and you had a very, very high PSA for that very small gland, you'd have a very high PSA being divided into by a small volume. That actually comes out to be a large number, relatively speaking. Conversely, if you had a very small PSA and a very big prostate, that's the basketball side, but that individual had a very low PSA, you're going to generate a very low number when you do that ratio, when you do that division. So PSA density is really a surrogate for volume of disease. And when we see those cutoffs over 0.15, we get concerned that there's going to be something more going on, some higher grade disease that's present there that we perhaps didn't pick up on that first biopsy. So these parameters here, these items here are associated with reclassification within 3 years of the start of active surveillance. When you go out to 5 years, genomic score it doesn't become as important, but the kinetics of the PSA, how quickly is the PSA changing, as well as the PSA density is what remains associated with that risk of reclassification at 5 years. So active surveillance has limitations. We've sort of been alluding to that with regards to the risk of occult higher grade disease. So it really is an undersampling problem that despite doing the number of biopsies that we typically do, either with template or with targeted biopsies or a combination of both, that we may be undersampling and not being able to pick up that higher grade disease. We certainly require frequent blood sampling. Men have to go in quite often to get their PSAs drawn. Now, as I think I've spoken before to the group, PSA, we refer to it as physician-patient stimulated anxiety. And you don't get away with that from that either with active surveillance or after treatment. So that frequent sampling, that anxiety is an issue that can sometimes, in some individuals, lead them not to seek care and continue on the protocol. And that can be a real problem. We have a repeated biopsy risk. We know that there's pain and discomfort associated with it. Starting to be reduced, we do have techniques, clearly local anesthetic, as well as nitrous oxide, but these are not complete. It's not a general anesthetic. And some individuals simply can have a lot of discomfort from that standpoint, not only from the biopsy itself, but also with the probe in the rectum. And it's a tough one it's a tough problem to really try to overcome. There are the clinical risks of the biopsy. We have the risk of bleeding and infection, which is not insignificant. And we have to keep that in mind. We have the issue of repeated bacterial coverage for bacteria with antibiotics, which can also lead to resistance and less antibiotic availability for the treatments, and then potentially also for other reasons. The expense, insurance coverage being what it is, it may be incomplete, and there may be out-of-pocket expense. Nitrous oxide is not covered by insurances, unfortunately, and so there's an expense with that. So these are issues that can limit doing active surveillance. There is a lack of consensus on how often we should be doing the surveillance. How often should we do the biopsies? When should we do the first biopsy after the index biopsy is done? How best to do that? Should we do it by MRI targeting only, or should we do a template type technique, or do a combination of both? After that typical confirmatory biopsy, what do you do? What's your interval for you doing your repeated biopsies? How often should we be checking PSAs? There's no consensus on that. Part of this is also affected by the variable biology and natural history of prostate cancer. Not only do we see it in populations, but we also see it in a given individual. And those are intangibles that's very difficult to get our hands around. Perhaps with more genomic assessments very early on, we'll have a better sense of that. But that's yet to come into full usage. And then alterations in surveillance based not on the biology of the cancer itself, but really the patient-related concerns. I related to you about the anxiety, and that can be due to the anxiety about the procedures, about frequent testing, trying to fit it into work schedules, and sometimes even leisure schedules. We have patient comorbidities. We have individuals who are on anticoagulation. They have diabetes. They have other issues which may increase the risks of problems. And then, of course, within the last beginning a year ago, we have the COVID concerns, and we have a number of patients who have restricted their coming into the office. That's for active surveillance and doing biopsies, but even in individuals who already have active disease and on treatment. So that's a real problem. And I think down the road, when, I'm sure it's going to be when we get out of this, not if, but probably a year from now, we're going to probably see this kind of a swell of individuals coming back to us with potentially more advanced disease, and that will be a real tragedy. What are our current controversies? Probably the big elephant in the room remains intermediate risk disease. And this is what we consider Gleason group 2, that's Gleason 3+4. It's not 4+3. 4+3 is not someone, in my opinion, and I think it's shared by most providers, that it is a good candidate for active surveillance. It's not clear, though, that all men with Gleason 3+4 should undergo definitive treatment. We certainly have data that, at least anecdotally, individually, some men will do very well with low-grade, low-volume 3+4, low-volume grade 4 in that Gleason 7 disease, so small amount. We understand that cancer is best assessed with analyzing multiple variables, not a single one. So 3+4 by itself is not necessarily a reason not to offer active surveillance. As I alluded to earlier, volume as compared to grade actually has been shown to be a better predictor of adverse pathology. So a single core of 5% 3+4 versus 7 cores of 3+3 may actually be a better predictor, and that individual actually may wind up doing better than the large volume. Also looking at the subtype of the Gleason 4 pattern, and there are types that are called expansile or cribiform. If they're poorly formed or fused, those portend more aggressive disease. We don't always get that information from our pathologists. They don't always classify it in that way, but that would certainly be an area that would be beneficial for us in managing our patients. Other areas of concern really are just influencing factors on its use. That has to do with the education level of our patients, the type of insurance. We still have a lot of problems, and clearly in California, and the way that the insurance field is here, it's so widespread and so different. It's challenging. They found, at least in this study, that proximity to healthcare facility, and you can imagine if someone's in a rural community versus an urban community, maybe less likely to adopt active surveillance or for it to be offered because of ease of access. And then differences between academic and community practice. The academic centers, probably more often, there are, I'll say that Genesis is the exception to that, in that we've adopted and really made active surveillance a very important part of the care that we offer our patients, but not all practices are really set up in that fashion. The follow-up protocols also remain controversial. If you look at NCCN guidelines, they certainly are recommending active surveillance for very low risk and low risk, but there's not really data-driven information regarding how to follow up these patients. What's the optimal follow-up schedule for them? We see different protocols in different places. You see it academically, but you also see it certainly in the community as well. There are efforts underway to try to address these variations, and it's really being focused more on classification and the reclassification of the risk of that individual. How likely are they or not likely to progress? And to that end, the Canary Institute, which is a multi-center prospective active surveillance cohort study through the Canary program, which involves 9 North American centers, UCSF, Stanford, multiple others. And they've recently published their data on this validated multivariable model. So here we are, multivariables to take a look and to account for it, to really try to identify which individuals don't need as intensified surveillance regimen, and who are those that really do. It really is a guide to shared decision making. You can find this online. I list the website there. That's what, when you pull them up, that's what it looks like. You can see here that they have both a biopsy calculator for the current risk, as well as one for future progression on active surveillance. So again, not to be taken in isolation, not to be taken as gospel with regards to what to do, but it really enters into the entire picture of how you manage a patient and really making that shared decision with the patient, and that's really critical. Another example is what we've done here in Genesis. I mentioned that we have an active program with that, and it's actually not just actively being performed, but it's actually being monitored for compliance. You can see here, really focusing in on the top 2 curves. We really had our intervention back in 2013. So, we're now 7 years out in terms of doing this. And that was 2 years after Genesis was started. So you can see at that start, we were really close to 50% in terms of offering active surveillance to our very low risk and low risk individuals. And then upon instituting the program, by a year later, we had actually significantly increased the participation. The method that we did that was a reporting of all individuals as to what their adoption of active surveillance was. But not only was it individually reported to each provider, but it was published so that everyone within the group could see what other people were doing or not doing. So perhaps using a little bit of shame to be as an instigator, we saw that we had a significant improvement. And then we kind of dropped off a little bit, we plateaued. Part of that was for lots of reasons. We were going through a bit of change within the group. Our monitoring and our reporting kind of dropped off to some degree. Then recognizing that there was the issue that we needed to do that clearly was a stimulator to do that, we restarted up the reporting. And you can see here that as we've been increasing over time, and we actually reported this and published our data. So I think we're very proud of that we've been able to make great strides and headway into having patients not only adopted, but able to monitor and care for them appropriately. So wrapping this up in conclusion, I asked the question at the beginning, have we come a long way, baby? And I think the answer is yes. Active surveillance is clearly the preferred form of treatment for very low risk and low risk individuals. And more and more data indicates that it should be considered and carefully, and I emphasize and underline the word carefully, selected favorable intermediate risk. Those are the Gleason 3+4. We have new technologies that are assisting us. They're able to take into multiple variables. You've got the validated tool with the Canary Pass program. We have multi-parametric MRI. We have genomics. We have markers. All of that to be able to assist us. And no doubt we will have more in the future. Protocols for surveillance are variable. As the adoption of active surveillance, I think you really need to have something, as we've done, and many groups are starting to do that, so that we can sort of keep our nose to the grindstone and make sure that we don't have patients dropping off, and ensure that we continue to provide that level of care. We certainly have further refinement that we need to do with regards to the uniformity and how we approach it, both not only in risk assessment, but our follow-up. Ideally, we would have less burdensome evaluations for appropriate individuals, very low risk and low risk groups. So schedules are perhaps a little bit better. They're more likely to be compliant with the protocol. And then look to see with not only what we have now, but in future directions to expand the eligibility to more men in the intermediate favorable risk group. That's the 3+4 group. Caution is the guide word for those individuals with Gleason group 2, 3+4 disease, cognizant of that PSA density number, what the MP MRI demonstrated, what the genomics are, and it indicates that things are adverse. 3+4 is risky, and so we have to be careful with it, but it doesn't mean that it can't be, active surveillance can't be utilized for it. And again, taking a look at the number of biopsy cores also is a factor that needs to be considered with its adoption. And that's it.
Great. Well, that was a wonderful presentation, Doctor. A lot of very useful information there, especially for our new members that haven't started any treatment yet. There are a number of questions that have already come in online. I'll let you start reading that
Sure.
first one there.
Okay, so I won't read the name, of course. Late 50s on active surveillance and on 4 years. PSA has been vacillating a little bit, about 3.5 up to 6.5, which was a longer time ago. Previous result 3 months was 4.5 or so, and 1 week ago 9.5, so it doubled more in three months. So yeah, I mean that's the pattern here to me has been really quite stable. The increase is somewhat concerned, although again, PSA kinetics can be due to other things. So the issue, then the question I would say is that the individual's been on for 4 years on active surveillance. Was there confirmatory biopsy? Were there surveillance biopsies being done? Was an MRI obtained? Were there any genomics? I don't know what the Gleason score here is, but you would consider genomics. You'd look at the Gleason score. With the current elevation here up into the mid-9s, I would want to make sure that there isn't any indication of inflammation. So a urinalysis.
By the way, he actually did continue his question and add some more information specifically about that.
Oh, okay. Am I missing something here?
No. It got split over 2 questions. Probably, yeah, the way it just worked.
Okay, is that somewhere else for me to see where the rest of the information is?
Oh, the second question that came in. I guess I'll read it if you can't see it there.
Okay.
It says I had a kidney stone.
Okay, forgive me. I'm so sorry. I apologize. Getting used to the technology. So,
Yeah,
all right. So there was a kidney stone and cystoscopy that was done in a manipulation. That clearly is going to change the PSA level. So with the PSA done 1 week ago and the manipulation 2 weeks ago, you really need to wait several weeks and probably a month to check a PSA. I would not have checked a PSA after manipulation like that. That clearly is a factor that has to be considered on interpretation. And so what I was really going to say is that really needs to be repeated to ensure that there's a in fact, let me move my camera here a little bit if I can. No, don't let me move it because I'm not staring into the camera. I apologize to read the questions. That needs to be repeated. And I would have done it even if you had not had the manipulation done. I would have repeated it for consistency because PSAs come and go, and that's why we see that again, variables in isolation don't always show the picture. Yeah, Reese tested next week. So if I am, that's going to be about 3 weeks after the manipulation. I might wait even an additional week. It's not going to be harmful to wait another week. Give it a little more time to come down and see where things are at. again, I would still say you need to take this in context to say, what was the original grade and volume of disease? Was there an MRI done? Has there been an MRI been done since? Was there a confirmatory biopsy and any surveillance biopsies? And then kind of go from that standpoint. If the level was still elevated, I would definitely try and get an MRI. I would make sure that examination hasn't changed. So a digital rectal examination, is in order. And then putting that information together, then to consider a biopsy, depending on some, all the other factors put together. But that would be a reasonable way to approach it.
Great. Could you, in a related note, can you touch upon what temporary factors what other temporary factors can affect the PSA? For example, I remember that a recent sexual activity can cause an increase in the PSA. Is there anything else that can cause it to fluctuate?
Yeah, so recent sexual activity, infection, inflammation, which can be present by virtue of white blood cells in the urine in a negative culture. So again, under infection, we're talking about prostatitis type conditions. Manipulation, just as in a surgical procedure, catheterization also can occur. Also, from a personal experience with my patients who are really heavy duty cyclists, and I'm talking about people who are like, cycling 75 plus miles and so forth. I generally recommend not to get a PSA level done for about a week after that last cycle. That's difficult sometimes because they're doing it multiple times, but we may get a baseline PSA on them, see what it is. If it seems that it may have elevated beyond the baseline, then maybe repeat it again with abstinence from the cycling activity and see if it makes a change. So those are things that it can certainly influence a PSA level.
Gotcha. I think the next question is also split over two entries there.
Thank you.
I think they meant to say in terms of determining a number of cores positive.
Okay, let's see if I'm interpreting this correctly. So looking at the number of cores based on template or target. So if you were to do a pure target biopsy,
and you know what, doctor, I just noticed if I scrolled down, I think that her question did also get split over multiple windows. So there's, or his, I mean, sorry.
No problem. Template in general, 12 cores, where target biopsy can be more than 12 cores. For example, baseline 12, additional 3 cores for each suspicious lesion, gave me up to 18 cores. So yeah, it is going to be a different thing between a pure targeted biopsy, which is done through MRI guidance. The radiologists are the ones that do that, like Dr. Schwartzberg and company, many others. They will only biopsy the target lesion. And so there is the potential for undersampling when you only look at that particular target. We know that MRI can have up to about a 20%. I've seen as high as 24% false negative. Okay, and that's a problem that the MRI does not identify the malignancy, whether it be low grade or high grade. And of course, MRI is really principally targeting high grade disease. Okay, that's what it's really going to be able to pick up. So if you're looking at the number of cores, you really are trying to get an idea of the entire prostate. So you're really looking then at a template type of biopsy. That's the only way you're going to know if it's a bilateral process and how much is really there. So my practice is that if we can get an MRI when the patient first presents with elevated PSA with or without an abnormality, and we're going to do a biopsy, I try and get an MRI if I can. I think it's very beneficial, especially in large glands, because we know that's the sampling error with a standard template biopsy. If you have a prostate that is 75, 80 grams, cubic centimeters, you're not going to ever target the anterior or the central zone. You just simply don't see it. You're not going to be able to identify it. So the MRI helps us from that standpoint. So if there is an abnormality, I recommend the biopsying of the MRI abnormality, the target, as well as the standard 12 core. I also do so most of the time in surveillance, confirmatory and surveillance biopsies. Much depends on the time frame. Much depends whether an MRI was done. So if I have a patient who can't get an MRI and I do their template biopsy or their 12 core, because that's the only thing I can do, and I identify malignancy, then if they are a candidate on that basis for active surveillance, their confirmatory biopsy is going to have an MRI before that. If I'm concerned that there may be occult disease that we didn't pick up based on the MRI, because of the proximity to the 12 core template biopsy, I'm probably will only have a target biopsy of that area. And that may be about 3 months afterwards, 4 months afterwards, to get that follow-up information. I don't need to do another template biopsy for that individual. But if they're out 2 years or 3 years and it's a surveillance, the MRI may not show anything. It's going to be a template anyway under those circumstances. If the MRI shows something, I'll do both. And that way you really get an idea of the volume of the disease to the best that you can, and be able to then look at that as a factor, whether we are perhaps missing some occult disease on the basis of volume. I think also over time, remember I mentioned that volume is a better parameter, so that so initially, if you have a small number of cores, even on template biopsy, you want to go back and do another template simply to know, have I now increased the number of cores? Am I dealing, maybe the first one was a unilateral, it's only one side of the prostate. Without doing the template, you're not going to know if there's something on the other side, which is now we have bilateral disease. And that's another factor that has to be taken into account in terms of progression. So there's a lot of nuancing here and a lot of things that you have to parse and take a look at, and a lot of moving parts. But that's kind of the way, I think, the best way to manage it. That's how I do it.
Right.
All right. I think there was one up above here.
Yeah, the first one now.
Okay. When you mentioned no consensus on frequency of follow-up biopsies, what in your practice you recommend for maximum amount of time between biopsies? A low volume, 3+4, 7, negative DRE, PSA found stable, unchanged PSA. If the PSA doubling, or rather PSA density is actually 4.7, that's a concern. Again, it's 0.15, and that may be a misprint, and so please correct me if it is. But if it's actually 4.7, that's very, very high, unfortunately. And so I'd be concerned. At least with regards to the biopsies, I'd be doing that. Even let's just take a generic situation of a 3+4 low volume, what we call a T1C, non-palpable disease. We feel nothing on the examination, stable PSA. I definitely would have done if that was the first biopsy, I would have done a confirmatory biopsy, probably at anywhere from 6 to 12 months. I would have probably tried to get some genomic molecular markers on that 3+4 to see if it gave me some sense of progression. And then depending if that looked to be favorable, then I would probably move the biopsy out, maybe out to 12 months. That would have been the confirmatory biopsy. Based on that information and MRI findings, which I would have wanted to have it before that biopsy, then determine whether the biopsy needs to be done in 1 year, or it can go out to 2 or 3 years, depending on the situation and what you find. I've seen individuals where I had 3+4 disease on a couple of cores that the patient elected active surveillance. I would have recommended something different, but they stuck with active surveillance, and lo and behold, surveillance biopsy didn't find any cancer. Mm-hmm. Now, does that mean it's not there? No. Does it mean that it spontaneously involuted? Possibly. We did have an MRI before, so that was very beneficial to us too. So, you have to, again, everyone is different, situations are different, but that is, you have to take a look at that entire thing. So again, there are some developing consensus in terms of biopsies. For the most part, after initial biopsy, the confirmatory biopsy is 6 to 12 months in most cases. Some, if it's very low grade disease, say a single core of 3+3, you might go out to 18 months to do a confirmatory biopsy. But that confirmatory biopsy in that time frame And then your follow-on biopsies are going to be in some interval of every 2 to 3 years if it remains favorable from all the different variables that you take a look at.
Yeah. An interesting thing I caught you saying that I hadn't heard before. I guess that a biopsy core will have enough material to do a genetic test on?
A genomic test.
Genomic?
A genomic molecular marker. Okay, so you're looking at a Prolaris or you're looking at a genome DX. Now you do have enough in there. Prolaris requires, I think, at least 10% of the core with malignancy for them to be able to run their test. Genome DX, the way they do their testing can have, I think, down to about 5%, even 5%. They can sometimes get material out of that. So you can do it on relatively small volumes. If I had, for example, if I did a biopsy and I did an MRI, let's say beforehand, and it was negative, and I did a 12-core biopsy, and I had a single core of 3+3 that was 5%, I don't think a genomic molecular marker like Prolaris or Genome DX is going to be terribly helpful for me. That individual, as long as their PSA and everything else looks good, there's no family history of prostate cancer. Again, these are things that I didn't mention, but they're important to take a look at that you'd say, okay, we're probably not missing anything, especially with having that MRI. So that marker is probably not going to help me in the short term. And I may not be able to get much of a study done anyway because the volume is so low. So we'll just watch them clinically from that. So that's what I was referring to.
Great.
All right, next question. Quandary for individuals that initially seem to be in the low risk category, and then there's a sudden rapid rise in PSA readings. Yeah, that kind of goes back to the other situation where, was there any manipulation? Was there anything that might have artificially elevated the PSA level? Was there an MRI that was done? Was there not an MRI that was done? Were there any genomics done? All of that is going to be useful to determine how do I interpret that rapid PSA rise, get a urinalysis, make sure there's nothing going on. You will find individuals that do have bacteria in the urine, and they are completely asymptomatic. So they really don't have a quote prostatitis, but they have some bacteria, may have some white blood cells, could possibly be enough to change that PSA. So that has to be evaluated, has to be followed up. Again, I would repeat it for consistency. It's amazing that PSA bounces around like one of those super balls that I had when I was growing up as a kid. And so you look for consistency, you look for the things that are going to tell you, do I need to intervene? What was the time frame from the last time that I did the biopsy? Are we overdue for various reasons, COVID or health reasons or whatever, from that last biopsy that would have normally been done, a confirmatory or surveillance biopsy? So it's not grounds for panic. In my opinion, it does need to be investigated and followed up on and get an answer for it. And if it is up for no other obvious reasons, then it needs to be reinterrogated. All right, let's see. Let me, I think, they're all coming at the same time here. Okay. Thank you. Well, thank you. I believe, touched on the presentation, I'd like to know your comment on how subjective are the interpretations of prostate biopsies? What's the error associated? I'm going to assume that you're talking about the histologic interpretation, whether it's a 3+3 or 3+4. You have to know who your pathologist is. That's very, very critical. We're fortunate in Genesis to have a GU specialized pathologist. And so we feel very confident with him. We've had some patients ask for second opinion. So they've gone back to Jonathan Epstein at Hopkins. And there's been very, very good concordance between the reads. We haven't seen anything that has come back on a major. That can vary based on where it's being read. I cast no aspersions at any of the national laboratories. They usually have a peer review on their assessment. So usually you're getting more than one pathologist from that standpoint. So by and large, I don't think there's a lot of variability in that. If there is, it's sometimes what you'll see is the amount of grade 4 being present, or the amount of grade 3, that kind of a process. Every now and then you will see that there is something more going on, and they didn't call it that. Grade 3 is probably the most, I think, the easiest that they're going to call. When you get the 4s, that may be an issue that you'd want to know about. You might want to know that maybe this is not a 4, but there's some 5, unfortunately. So that's the area that it's probably not unreasonable, depending on who your reader is, who your pathologist is, you might get a second opinion on that. How does ultramicrosound factor in active surveillance? Well, it actually factors in, I think, very, very well. Now, maybe I'm biased, and full disclosure, I mean, we're I think, one of 2 in San Diego that has the micro ultrasound machine. UCSD does. I don't know really how much they really use it, but I think it complements MRI very, very well. We're collecting our data. I don't know if we'll ever publish it, but we're looking for concordance with MRI and the ultrasound. And I get those reports every month, because where we have our machine here at the Cancer Center, I'm the principal urologist performing the fusion biopsies with MRI. So when we look at those kind of numbers, we are really seeing that, yes, we have concordance. Not only do we see a micro ultrasound abnormality aligning with the MRI abnormality, we see that quite often, that we're able to see that. We also see other areas, especially in the peripheral zone. This is really where its utility is, in the periphery of the prostate, that we'll see areas that the MRI did not pick up, and we will find, I won't say routinely, but we do find a number of the times that we'll find malignancy in those areas that the MRI didn't pick up. But it's not the fault of the MRI. The MRI is really focused on trying to get and try to identify high-risk disease. It's not really something for low-risk disease. Low-risk disease is going to be occult on MRI the vast majority of the time, unless it's very large, probably the only way you'll pick it up. So what I'm typically picking up is low-grade Gleason 3+3 disease on that. Now, that can be important in terms of volume, in terms of what we're seeing. But usually, if you are going to find someone with high volume 3+3 disease, greater than 50% of the cores being involved, that's where your template biopsy is going to have picked that up. And we may or may not see anything on the ultrasound specifically different from that standpoint, because everything looks the same. But you can find specific areas. And so I think it's complementary. I think the other place where it really serves well is for individuals who can't have an MRI, either from a standpoint of insurance coverage, or they have a implanted defibrillator, they got a pacer that won't allow them to have an MRI, they have some other reason that we can't get it. Potentially they've got bilateral hip replacements, and now we've got some attenuation. We don't see things really clearly within the MRI. I think the micro ultrasound can really help us under those circumstances. So it's a nice tool and a nice device to have.
Do you use that micro ultrasound on nearly all of your patients? I mean, is it basically kind of like we've got it there, it's practically free, especially compared to the MRI?
Yeah, I mean, I don't have the micro ultrasound is a 29 megahertz. The standard ultrasound that most urologists have is 7.5, 7.5. I don't have a 7.5 in the office here. It's all micro ultrasound. Okay. And the other thing that I'll have some of my colleagues do is they'll send me individuals even before an MRI, before a biopsy, and I'll interrogate the gland. I'll investigate. I'll just use ultrasound without biopsy and see if I see areas. And we often do find areas that are concerning. They wind up coming back to me for the biopsy many times, but at least we can identify areas that we can plan for our biopsies for them. Okay, I'm on as I have a urologist. I see. Would it help me to see you? I'd be happy to see you. I'm happy to see anybody, even as a second opinion or whatever else has been going on. But yeah, my door is open. As I tell my patients, I don't have a red carpet, but the door is always open during normal working hours. So come and see me. Happy to help in any way I can. Okay, John, I'm sorry, my question got received. My question is, let's see, how would you help? How would it help? Oh, how would it help me to see you that I'm not getting now? Boy, that's a tough question. I don't know, obviously, what's going on for you, what's being done, confidence in your urologist, you feel comfortable in speaking to them. these are all things that I think can be barriers. Language barriers can exist as well. I do speak Spanish. I think it can help some patients who English is not their first language. So again, I'd be my door is open. I'm happy to see you. At least a second opinion. We could go over everything if that would be helpful for you.
Yeah, I would say from my experience, if I'm a patient and I have the least, even just one question about the care that I'm getting, it's certainly going for a second opinion is got to do it. Yeah, can't hurt. Can't hurt.
There's nothing like reassurance. You can't put a price on it. You can't put a price on it. All right. Let's see. Okay, here we go. Germline mutation testing. If you have to choose these two providers, color.com or Invitae. I'll be honest with you, and I'm not familiar with color.com. Germline mutation testing, the two companies I use are Invitae or Myriad. I use probably more Myriad. Again, full disclosure, I speak for them. It's not really the reason I tend to use more Myriad. And I'm not dissing Invitae. I think they do an excellent job. I think Myriad has the largest library with regards to genetic variants, and there are things that are called variants of uncertain significance. All our genes have a particular a pattern of the base pairs that make up the DNA and make up the gene, but there can be minor variations in those. And some of those variations we know very well are associated with malignancy and disease. That's the BRCA1, the BRCA2, ATM, so forth. Okay, there are other genes that have variations that we don't know if there's any disease associated with them. They're of uncertain significance. What these companies, Invitae does it, Myriad does it. I just think they have a larger experience pool because they've been working with BRCA for so much longer. They're the ones that developed the first test for it. They actually then will, every time a variant shows up, they put it in the library and they compare it based on information that's come in to see, has that level of significance changed? Is it now clinically significant, or can we say definitively it's not clinically significant? And I've gotten a number of those reports on patients. We see the variants all the time, but I know that I'm going to be contacted, the patient will be contacted if there's when there's a change, either in favor of it's not an issue or that this is now an issue, we need to do something about it now. So that's why I'm a little more comfortable with them, but I have a lot of patients who get Invitae because of the insurance issue, and I've been very happy with the quality of their reports, how they present that out. Both companies provide genetic counseling free of charge. We used to have patients come into the office in pre-COVID days, and they would just sit in the conference room. They have as many of their family members there. They could listen, talk, ask questions. So those are all things that that the companies provide. Both of them do, and you can do it now from home on the telephone, so you don't really have to come into the office anymore. But I think they're both great. I've just had a longer working relationship with Myriad, so that's. How
do you spell Myriad?
MYRIAD. 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 Myriad.
Great. Someone had a question on that. So.
Oh, okay. Okay. So here was the PSA density, 0.047. Yeah, that's very low. Thank you. We can all breathe better on that one. Yeah, that's extremely low. It's less than I think. Let me see. 0.15. So 0.04. That's excellently low. Hey, that's a lot of favorable findings there for that person. So good news. Okay. Let's see, I've got biopsy indicated 1 benign, 3 6s, 2 7s, complication signaling on Southern California biopsy. How many would indicate this low level? All right, how do I diplomatically ensure that my doctor is up on all these studies? I think UCSD is a great place. I participate in their tumor board. They're all on top of that situation. As I said, that's they've been producing a number of clinical trials, clinical studies, and papers that they've written. They wrote the one on the African American. use of active surveillance and very favorable numbers. I think UCSD is a great place. If I have to be careful what I say, I better not say anything. I think they're great. So that would be a fine place to be taken care of. So a lot of confidence in them. Okay, is that the last? I think that's the last one. Am I getting that right, Darren?
Yeah, actually, had you answered that one?
Yeah, this was the one with the 1 benign, 3 6s, 2 7s. Where biopsy, how many indicate this low level of adenoma? I think most places would have identified it. I'm going to, I don't know how the biopsy were done, whether you had an MRI prior and you had both MRI and template, or was it just straight template? Clearly, with the numbers, you would have had to have a template. If there was an MRI there, is this the first biopsy? Is it a subsequent biopsy? I think most places, I'd like to think that we would have identified those kind of numbers for you and been able to present that information to you. But I do think UCSD is a great place. So I think you're fine.
Gotcha. Great. I actually had a few questions of my own as we were going through the presentation. If
Sure.
We have a few more minutes here. I was just kind of curious when some of these studies were done, such as the Pivot study or the Swedish study, when a patient was assigned to active surveillance, that one of those went on for 27 years. Did any of those patients ever, change their mind and 10 years down the road then have radical prostatectomy or other treatment?
I don't think in the Swedish study they were pretty. I had to go back and look at the prime source at the study itself and see if there was what kind of a crossover from that standpoint. If I recall on Pivot, and again, in any type of clinical trial, at least in this country, you can opt out immediately, and so you'd have to look at that. Have to go back to the prime source from that standpoint. I suspect there probably were, but I can't. But I couldn't swear to in a court of law exactly how many that there were under the circumstances. Sweden handled things differently, and they clearly did back then. Their approaches were a little bit different. They waited much longer, and I think that's part of the data and the controversy with screening, where they really weren't doing it for quite a long time. I think that's changing now as a result of what we found. But yeah.
And most likely, then the results that they were comparing the two groups, like anybody who did switch, they were basically just removed from those end reports.
Exactly. Yeah. They would not be included. So whenever you report those out, you'll say, it's this number of patients started, but due to other things, these are the numbers we're reporting on. So you always want to know what your initial pool was, and then the wherefores and the whys, the rationales for dropping out, and what your total number is. Yeah.
Gotcha. When you consider that a patient under active surveillance might, see you once every 3 months, 6 months, once a year, something like that. Many times we'll be at home, our brains are turning like, should I be worried about something else, sooner? For me, I know that I actually only proceeded with getting really a second opinion once I actually was developing some urinary difficulties and actually having physical symptoms. Do you expect patients to have any physical symptoms during active surveillance, or is that kind of an indication that something is changing and it needs to be looked at immediately?
Well, the latter is certainly true. I mean, that needs to be addressed clearly for two reasons. Number one, yes, it could represent a progression of disease. You can't exclude clinical findings. It's not just pure number of PSA and PSA density and PSA doubling time and genomics and so forth. The patient has to be considered from that standpoint. So the other thing, of course, is just symptomatology and bother of the patient. Let's say you started with a patient who had a 100 cc 100 cc prostate, 100 gram prostate. Well, over time, you may well expect to develop the more typical BPH type symptoms. So whether that represents malignancy or it's just BPH, and under the current under whatever the circumstances are, it deserves to be assessed. But because BPH typically is not, if it has a potential life-threatening aspect to it, And prostate cancer does, it definitely needs to be addressed if it's in between. So, yeah.
Gotcha. Gotcha. And this question is probably just goes without saying, but what type of doctors should be overseeing active surveillance? Is it urologists only, or is it something that can be left to the primary care physician?
My bias is that it needs to be by a urologist. I don't think the primary care physicians have the knowledge, and you can see this is a changing landscape, and so you need to stay abreast of the information and what you do and how you do things. To interpret PSAs, I mean, unfortunately we still have a lot of problems with primary care physicians who don't order PSAs. And that's why we're still having individuals showing up with advanced disease, either locally advanced or metastatic disease. You know, unfortunately, I'm probably seeing upwards of 5 patients a month with that. It's tragic. And again, I think as a result of COVID and people not coming in, and certainly not coming into their primary cares. I mean, yeah, I've got patients who I'm seeing, they need to see their primary care for comorbidities, and yet their office isn't open. They're doing everything by Zoom, and you can't do everything by Zoom for patients. So it's a real problem with that. So I would not leave active surveillance to a primary care provider. I don't think they know enough information. I don't think they know, for example, you might have an individual who's got a lot of BPH, they're on finasteride, and their PSA is going up on finasteride. That's a red flag, and many times it's not picked up. So it really needs to be a urologist, I think, in my opinion.
I totally agree with you, and I kind of asked that based upon my own experience, because I was one of those high risk or highly advanced disease patients that came in after a primary care physician pretended he knew what he was doing. Let's see. I had a curious question. So you talked about PSA density, but I'm kind of curious, do you ever derate the PSA kinetics by prostate size? So is like a doubling of a large prostate while the PSA is somewhat low, less of a concern than if you had a small prostate and suddenly had an increase in the PSA? It kind of seems to me to make sense that
it does, but I think it's more germane and more problematic if you have a small prostate that went up quickly as compared to going up. But I wouldn't ignore it even if they had a big prostate. I wouldn't attribute it to prostate volume. In other words, okay, if your PSA is going up, it's not because you're doubling the size of your prostate. It's not going to be a volume of the size of the gland, clearly, and clearly, more adenoma, potentially for a somewhat higher PSA. But in the presence of a known diagnosis, and we're not talking about screening for prostate cancer here, but a known diagnosis, I think that PSA elevation needs to at least be considered and addressed, depending on where you are in the surveillance protocol. Again, what's been done, biopsies, MRI, and so forth. I think we're turning more and more to MRI for some of these circumstances of initial PSA increase if there's no other explanation for it, because I think it can be quite helpful with regards to follow-on recommendations for biopsy, how to do the biopsy, what we're going to be biopsying, all those sort of things. So MRI is taking more and more and more of a role on. I don't think that MRI can be used as a surrogate for biopsy. That is to say, your MRI is negative, you don't have to worry. We're not at that point yet. I think there's a lot of variability on how MRIs are read. So again, much like the question about pathology variation, there's, I think, a lot more variation on MRI reads. There was and I won't mention names, there was a center here in San Diego who, we didn't get a PIRADS reading on the findings, which was problematic to me. And so these are things that you have to take a look at and consider, and that's my job as a urologist. And getting back to your original question, a primary care physician will know nothing about that information.
Very true. Having been a cyclist myself, that actually did cause some of the uncertainty in my early PSA, high PSA readings. I guess how how worried are you of a cyclist having a PSA of say 3 to 5? Are cyclists really a higher risk group because of the activity?
I can't point to anything in the literature that says that it is. I really look at it on an individual basis. And so, if the PSA is elevated, if it's elevated based on age, if I had a 25-year-old cyclist and his PSA was 3.5, I'd be very concerned. I would certainly repeat it. I'd ask him not to cycle for at least a week, check it, compare it, see what's going on. But if it remains elevated beyond the age, we're doing something about that. We need to investigate it. Whether it turns out to be that as a result of cycling and pressure and changes in the prostate, there's a chronically elevated PSA and there's no evidence of malignancy, well, fine, we've eliminated malignancy. But I would still want, it's still incumbent up to answer the question from something that standpoint. So I think more from a standpoint of looking across broad populations of cyclists and see where their PSAs are, and other PSAs higher than the other population. I don't know of anything that really speaks to that. Interesting thing to try to look at, get a PubMed search on and see if there's anything there. But I would still look at them individually, and that's a safe bet. Sounds good.
And would you also just perhaps touch on Genesis Healthcare as a whole? I was a little bit confused when I first tried to find a urologist, and it seemed like all of the urologists belonged to Genesis. But I was also given like a referral within Genesis when I also wanted to talk to a radiologist. So, like, how many locations do you have? What is the actual relationship between you and the other doctors, and information sharing and so forth?
Sure. So yeah, we are really turned out to be a multi-specialty group, although it's very limited in terms of our specialties. So I think we have something like 17 urologists, 4 radiation oncologists, and 5 gastroenterologists. And gastroenterologists are with us, and Mary's very, very nice with our business plan and pathology lab and so forth. So we have individuals that have specialized in particular areas. That's become their focus. So we have people who principally do stones, although they'll do general urology. We have people who do BPH. We have a number of individuals who will do things like urolifts and resumes and those sort of things. We have one provider who does principally probably 95% female urology. We have our really designated robotic surgeons within the group. So we've got people, and someone like myself who is just office-based and just principally doing prostate cancer, although I still do some general urology, but non-operative because I'm not in the hospital any longer. With that. So we have those resources for people who have that perhaps focus and bent to be able to take care of those particular problems. And if anything you do a lot of, you tend to get better at it. So I think that's good. Not that a general urologist can't handle a simple stone, but you've got a complex staghorn calculus or something, you probably want to have somebody who does a lot of those, got a lot of experience with it. So we're spread out. We actually are opening an office in South Bay, and that's going to be staffed with one new urologist, as well as 2 rotating urologists. We have La Mesa, we have 4th Avenue, we've got here at Kearney Villa Road, we've got both the Prostate Cancer Center and the General Urology Office. Then we have La Jolla, Encinitas, and now Rancho Bernardo. So we're kind of all over the county to cover. So we're not sort of in the center of the country, in the middle of the fields, and you've got one big city and everything is small, and everybody kind of comes into the big city for their care, for specialty type care. It's difficult for patients to move around within the city, and it's been a little bit easier with COVID. If there's no true silver lining to this disease, but the freeways were sure emptier for a while. I think they're filling back up again, so it was a little easier to get around. So it's always difficult for North County patients to be able to try and get down to Center City and things like that. So it makes it nice to have the divisions within Genesis of the different offices. when Genesis came together, we were all separate offices, separate practices, and then we merged together along with radiation oncology to create Genesis. With that, we've got 1, 2, 3 sites for radiation oncology. So, and a lot of this is dependent upon insurances, and not everybody takes the same insurances. We're still somewhat independent with regards to that. It's not uniform with that. Some of the IPAs and so forth, not everybody's contracted with, but we've got the major insurance people. We have got somebody who can take care of the patient depending on what their insurance is. So we'll do internal referrals, and of course we get also external referrals from primary care providers, other people who want second opinions. I've had some folks from Kaiser come over to see me for second opinions. I've taken care of a patient who contacted me from Baltimore. He had been to Johns Hopkins and multiple places, and he Googled me. I don't know where he found me on the list, probably down about 700, but I thank him for his diligence that he found me, and we've been able to take care of him long distance, and more of this is being long distance. I have patients in Mexico that I take care of. So all of that is from exterior, but then internally, at least for my office, for those individuals with advanced prostate cancer, they get referred to me as long as the insurance allows from that standpoint. I clearly get the referrals for the fusion biopsies. I'm just functioning as a technician. I do the procedure, I send the patient back, and whether they come and see me or not is based on their staging situation with that. So that's kind of how we work. If somebody is seen in, say, Center City at 4th Avenue, and it's an issue for a woman with pelvic relaxation, they need, if they're willing to travel up to Encinitas and see Dr. Juma, they can go up there. If they want to go somewhere closer, then we refer them to another provider. If it happens to be within Genesis, fine. If it's not something that we offer in a convenient fashion to the patient, then they can go. They'll go outside from that standpoint.
Gotcha. So new patients that would like to make an appointment at Genesis, I imagine just call your main number, talk to the receptionist, and they can also help direct based
Absolutely.
upon what insurance is required and so forth.
Right, absolutely. If they live in South Bay, and calling the South Bay office, I don't think they're quite open yet. I may be wrong about that, but they could be seen at the La Mesa office or the 4th Avenue office. They could call and then maybe see the urologist there first. Depending on what they determine the issues are, then they may have to then say, hey, come up to the Prostate Cancer Center if it happened to be that. Otherwise, they would take care of the problem there. They'd be more than happy to see them.
Great, wonderful. Well, I think that's all the questions that have come in. Thanks so much. We certainly got a lot of questions today, and so your answers, the time you spent on that is greatly appreciated. You had a wonderful presentation. We'll look forward to hearing from you again in the future with more updates, probably sometime next year.
Definitely look forward to it. Thank you so much for your kind attention, the questions. Wishing everybody good health and be safe.
Thank you. All right.
Take care.
See you next month, everyone.